Post-traumatic stress disorder. Diagnostic criteria. In order for an individual over the age of 6 to be diagnosed with PTSD, he or she must develop characteristic symptoms following exposure to one or more extreme stressors or traumatic events. These traumatic events may include, but are not limited to, A. Exposure to actual or threatened death, B. Threatened or actual physical assault, C. Threatened or actual sexual assault, D. Exposure to war as a soldier or civilian, E. Exposure to a major disaster, nature or man-made, and F. Severe motor vehicle accidents. Diagnostic criteria continued. The term exposure can be defined as directly experiencing the traumatic events, directly witnessing the events as it occurred to others, learning that the traumatic events occurred to someone close, example, family member, close friend, etc., experiencing repeated or extreme exposure to the details of the traumatic events. Symptoms. Symptoms of PTSD in those over the age of 6 need to be experienced for at least 1 month in length, although they may appear months or years after the traumatic event occurred. These symptoms include re-experiencing the traumatic events through distressing dreams and memories, emotional numbness and avoidance of reminders and efforts to avoid reminders, both internal and external, and stimuli associated with the events. These stimuli may include people, places, conversations, objects, etc. Negative alterations in cognitions and mood associated with the traumatic events beginning or worsening after the event has occurred. Symptoms continued. Examples of negative alterations in cognitions and mood are as follows: inability to remember an important aspect of the event, dissociative amnesia, persistent and exaggerated negative beliefs and/or expectations about oneself or the world, survivor's guilt, persistent, distorted cognitions about the causes or effects of the event that led the individual to blame him or herself or others, persistent negative emotional state, anger, fear, guilt, shame, persistent inability to experience positive emotions, feelings of detachment or estrangement from others, diminished interest in important or significant events. Symptoms continued. Changes in arousal and reactivity associated with the traumatic events beginning or worsening after the events occurred. This can include irritable or aggressive behavior, including angry outbursts and verbal and/or physical aggression toward people or objects. Note, outbursts can occur with little or no provocation. Reckless or self-destructive behavior, hypervigilance, exaggerated startle response, problems with concentration, and sleep disturbance. A recent study in which brain function was measured through MEG found that those with PTSD exhibited persistent hyperarousal and a very rapid double activation in the amygdala associated with emotional processing after viewing combat pictures, which was not seen in others who were measured. Diagnostic criteria, symptoms in children. Trauma experience in early life can more than double the risk of severity of PTSD and other mental disorders. Note, this is especially true for children in communities plagued by violence, examples war zones, areas with excessive amounts of gun violence, dysfunctional and/or violent homes, etc. For children under the age of 6, the definition of trauma and one's exposure to it is the same as those age 6 and over. The symptoms of PTSD in children are similar to those in adults. Note, however, children may often exhibit the symptoms via play, as in play reenactment. Children with PTSD may also experience developmental regression, impairments in relationships, and school behavior. In addition, children may also experience derealization and depersonalization. The individual becomes detached from their mental process and/or body and feels like they are in a dreamlike state. Prevalence. In the United States, projected lifetime risk of PTSD using DSM-5 criteria at age 75 years is 8.7%. The risk for developing PTSD varies across different cultural groups. The difference in cultural groups varies as individuals are exposed to traumatic events at different levels. In addition, the likelihood of developing PTSD after exposure to a similar traumatic event varies across cultural groups. The likelihood of developing PTSD is highest among survivors of rape, military combat and/or captivity, and ethnically or politically motivated genocide. Military sexual trauma has been steadily linked with higher rates of PTSD. Prevalence. Differences across cultural groups. There are recorded differences in regards to PTSD and cultural groups. According to a study focused on cultural differences and PTSD published in the 2011 edition of the Cambridge University's Journal of Psychological Medicine, the lifetime prevalence of PTSD was highest among African Americans, intermediate among Caucasians and Hispanics, and lowest among Asians. Caucasians were more likely to experience trauma, either directly, witnessing it, or learning of trauma experienced by someone close to them. African Americans had a higher risk of violent victimization. African Americans and Hispanics had a higher risk of child maltreatment and witnessing domestic violence. Asians, African American men, and Hispanic women had a higher risk of war-related events than Caucasians. Note, the study also points out that Caucasians are much more likely to seek treatment than members of other cultural communities, which was a limitation within the study. Risk and prognostic factors. The risk and prognostic factors can be divided into three domains: pre-traumatic, peri-traumatic, and post-traumatic. Pre-traumatic factors. Temperamental. If a child experiences emotional problems, including prior traumatic exposure and/or prior mental disorders by the age of 6 years, he or she is more prone to developing PTSD after experiencing trauma. Environmental. Those who are of lower socioeconomic status, lower education, experience difficulties during childhood, and/or have psychiatric family history may be more likely to develop PTSD. However, the presence of a strong social support system prior to the events may prove to be protective and indicate a decrease in the likelihood of experiencing PTSD. Genetic and physiological factors. Certain genotypes may prove to be protective or increase the risk of developing PTSD. PTSD is more common in adults who experience trauma at a younger age and in females who are more likely to experience trauma. Examples: rape and interpersonal violence within their lifetime. Risk and prognostic factors continued. Peri-traumatic factors. Environmental. The risk of developing PTSD increases based on the severity of the trauma, the perceived threat to life and/or personal injury, the threat/occurrence of interpersonal violence, and the experience of a feeling of disassociation that occurs during the event and may persist after. Current research suggests that the type of index trauma greatly influences the development and course of PTSD. Risk and prognostic factors continued. Post-traumatic factors. Temperamental. The presence of negative appraisals of one's self and/or the causes and effects of the event, inappropriate or lack of coping strategies, and the development of acute stress disorder increase the likelihood of developing PTSD. Environmental. Lack of social support, exposure to repeated reminders, and/or experiencing additional trauma increase the risk of the development of PTSD. Development and course. After the first year of life, PTSD can occur at any age. Symptoms most often begin sometime within the first 3 months of experiencing the traumatic event. Symptoms may be delayed for months or years after the events. However, this may be due to delayed expression. Delayed expression refers to the fact that the delay is not due to symptoms not being present following the events, but due to an inability to meet the full criteria. Individuals with PTSD. Their experiences usually do not form as a memory, but instead come back in flashbacks and nightmares. Those who experience acute stress disorder are at a higher risk for developing PTSD. Duration of symptoms may vary. In approximately 1/2 of adults, complete recovery occurs after 3 months. However, for others, PTSD may linger for longer than 12 months or even more than 50 years. The reoccurrence of symptoms is usually due in part to remainders of original trauma, the addition of other life stressors, or newly experienced traumatic events. In older adults, declining health, declining cognitive function, and social isolation may make PTSD worse. Development and course in children. For children, symptoms and the expression of PTSD may vary based on development. Young children may experience nightmares that are not content-specific to the traumatic events and express symptoms through play. Children may not manifest fearful reactions at the time of the event, but may focus on imagined events and become preoccupied with reminders of the event. Children may avoid people, places, actions, like play, and have reduced interest in new activities. For young children, pinpointing the onset and the symptoms may be difficult, as they may lack the ability to express themselves emotionally, physically, or verbally. In addition, they may be experiencing ongoing trauma or traumas, making it difficult to determine the onset of symptoms. For older children and adolescents, they may be reluctant to take part in developmental opportunities, examples driving or school dances, and may feel that they are now undesirable to or unwanted by their peers. For both young children and adolescents, irritable and/or aggressive behavior may cause their peer relationships to deteriorate. Additional effects of PTSD. Suicide risk. The risk of suicide increases with the experience of traumatic events. For those in the military with PTSD, the likelihood of attempting suicide increases with feelings of guilt, survivor's guilt, feeling responsible for the traumatic event and its effects, depression, anger, hopelessness, and an increased dependence on alcohol and/or drugs. Functional consequences. Impaired functioning with regard to social, interpersonal health, developmental, and employment decisions. Veterans find it difficult to develop relationships outside of the military field and difficulty taking part in family relationships in a positive way. Members of violent communities, gangs, also have difficulty maintaining positive relationships and making positive choices outside of their community. PTSD results in high economic costs and high levels of medical utilization or treatment, which makes absenteeism from work particularly harmful. PTSD also results in lower educational and occupational success. Comorbidity. Those who experience PTSD are more likely than those without PTSD to have symptoms of other mental disorders. Examples: depression, anxiety, and substance abuse. Children with PTSD are more likely to experience oppositional defiant disorder, separation anxiety, and neurocognitive disorders. For the U.S. military personnel, the likelihood of co-occurrence of PTSD and mild traumatic brain injury is 48%. In addition, the co-occurrence of PTSD and major depressive disorder is well documented, as well as co-occurrence of PTSD and major mood disorder. Differential diagnosis. Adjustment disorders. Diagnosed when the response to the stressor does not meet all PTSD criteria. Like PTSD, adjustment disorder develops after a difficult and/or traumatic event. Acute stress disorder. Those with acute stress disorder are more likely to develop PTSD. However, the duration of symptoms is much less, 3 days to 1 month. Anxiety disorders and obsessive compulsive disorder. Similar to OCD, PTSD involves unwanted and recurrent thoughts. Differential diagnosis continued. Major depressive disorder. While major depressive disorder can be comorbid with PTSD, major depression may not be the result of a traumatic event and does not include additional PTSD symptoms. Personality disorders. Difficulties in forming and/or holding on to relationships, as well as other interpersonal difficulties, are independent of a traumatic event, unlike PTSD. Dissociative disorders. If there is a presence of dissociative amnesia and/or any other derealization without the presence of trauma, it is not PTSD. Differential diagnosis continued. Psychotic disorders. When diagnosing PTSD, it is important to distinguish flashbacks from hallucinations and other illusions that can be the result of other disorders. Example, schizophrenia. Traumatic brain injury. While the comorbidity rate for soldiers with PTSD and TBI is high, it may be difficult to differentiate between the two, as the traumatic brain injury occurred as the result of the traumatic event. Note, it is important to be aware of the individual symptoms of each disorder. Treatment methods. An overview. While many feel that there is no real cause for PTSD, treatment can help reduce an individual's symptoms. Note, the most effective treatments have been developed within the last 25 years. Some studies have found that members of different cultural groups, example Hispanics and Asians, are less likely to seek treatment for PTSD. The unlikelihood of seeking treatment may be due in part to stigmatization and lack of education regarding mental illness, language barriers, mistrust of healthcare professionals, the misrepresentation of certain cultures in the mental health field, and reduced access to mental care facilities. Our society primarily associates PTSD with war veterans. As a result, its prevalence in other communities often goes overlooked. In communities with a high level of violence, there is often a lack of understanding of PTSD. Those who experience violence often do not seek help, and many hospitals neglect to screen victims for mental disorders associated with trauma. Resultantly, PTSD can go undiagnosed and untreated in many communities, particularly those of a lower socioeconomic status. Treatment methods. Cognitive behavioral therapy. Cognitive behavioral therapy or cognitive processing therapy. Process in which one changes the way he or she thinks about trauma and its aftermath. Many individuals with PTSD, particularly military personnel, blame themselves for the traumatic event and the decisions they made during and after the event. Cognitive therapy helps those with PTSD to understand that the traumatic event was not their fault and helps them cope with the feelings and emotions they experience. For some soldiers with PTSD, cognitive therapy involves writing about their experiences and how these experiences have impacted their beliefs about themselves and the world around them. These soldiers are then challenged to visit these feelings through different methods and change their views about themselves, the traumatic event, and the world. Note, research shows that this is the most effective method in treating and counseling those with PTSD. Treatment methods. Exposure therapy. Exposure therapy or prolonged exposure therapy. This method involves revisiting and discussing one's traumatic experiences repeatedly in hopes of changing one's reactions to the event and things associated with it. The goal of exposure therapy is to take power away from the memories via repeated exposure and discussion. This empowers the individual to become desensitized and handle their traumatic experience with more ease. In a veterans hospital in Arkansas, soldiers took part in a PTSD treatment program. Within the program, soldiers were introduced to exposure therapy by revisiting their traumatic event with a therapist 5 times a session. The therapy involves the session being tape recorded and having the soldier listen to the recorded session throughout the day. Other forms of exposure therapy may include exposure to virtual reality simulations and graphic films. These methods allow for the individual to revisit the situations and objects in which one has been conditioned to be fearful of. Treatment methods. Group and family therapy. Group therapy encourages an environment where PTSD survivors can speak about their issues with others who have been through similar experiences. Group therapy allows those with PTSD to feel more comfortable with their own struggles and provides them with a trusting and therapeutic environment to express themselves. Family therapy. Family members of those with PTSD often feel helpless and ill-equipped tackling this disorder. Family therapy helps build stronger relationships and creates a dialogue in which survivors of PTSD and their family can discuss treatment options, obstacles, and possible family dynamic issues that may arise. Treatment methods. Other options. Medication. Selective serotonin reuptake inhibitors and other antidepressants, example Prozac, have shown some success in treating PTSD by changing the chemical reactions within the brain. Eye movement desensitization and reprocessing. While the individual with PTSD is discussing his or her experiences with a therapist, The therapist encourages the client to focus on other stimuli, example, a hand tap, in order to control the individual's reaction to the traumatic experience. Note: there is still debate as to whether or not EMDR is an effective method in treating PTSD. Additional clinical trials. As many of the treatment methods for PTSD are relatively new, some PTSD survivors may want to explore other new and underdeveloped methods.